Thank you. I just wanted to thank you for having me here today. There's been an incredible lineup of talkers and speakers today, so I feel honored to be a part of this conference. So thank you to all the Susans and one Sandy. I have no disclosures to report. So what I'm hoping is by the end of my talk, you guys all understand what pelvic floor physiotherapy is and how we can help this population, as well as to learn how we treat and assess, and lastly, how to find a pelvic floor physiotherapist if there is a need. So what is pelvic health physiotherapy? It involves looking at the pelvic floor muscles through an intravaginal or rectal exam. Now, what's important is that we don't just look at the pelvic floor, which a lot of people assume. We look at the whole person, and we do this through a global approach. We do a full orthopedic evaluation, but we also use psychosocial validated outcome measures to determine if there is a need for other referrals. We've talked a lot about, the biopsychosocial piece, and we know that those with persistent pain do have a lot of anxiety and fear and distress associated with their pain. So again, we want to make sure that we're referring on if needed. So the internal component is really gold standard for pelvic floor education, and the reason being is because we need to determine what the dysfunction is in the muscle. Just like anywhere else in the body, there's two types of muscle dysfunction. There could be an overactive or tight muscle, so a hypertonic pelvic floor, or the muscle could be underactive or hypotonic. If you were going to see a physiotherapist to see or have your knee assessed, they wouldn't treat through a pair of jeans. What they would do is, of course, palpate and feel the tissues. So it's the same thing with pelvic floor function. So the hypertonic or the overactive pelvic floor, it can contribute to many exhausting issues, such as pelvic pain, dyspareunia, which is pain with intercourse, urgency and frequency of urination. So urgency is when somebody's reporting they've got a strong desire to void without much warning. And frequency of urination is anyone that's voiding more than 8 times in a 24-hour period. It can contribute to incontinence, and we'll talk a bit more about that in a few slides. Hesitation and retention, so difficulties initiating a stream or maintaining a solid stream of urine. Erectile dysfunction, painful ejaculation, low back and pelvic girdle pain, as well as constipation. Whereas the underactive pelvic floor muscles can contribute to stress urinary incontinence, prolapse, urge incontinence, urgency frequency, low back and pelvic girdle pain, and we'll go over a few of these. So why pelvic floor physiotherapy in this population? There has been a number of studies explored amongst those with EDS and pelvic floor dysfunction, and there's been a correlation found with urinary incontinence, prolapse, dyspareunia, and pain between those with classical type EDS. I want to just review the various types of incontinence, just so you guys have an understanding that there are different types. One, stress incontinence. What it really is when people are reporting a urine loss associated with coughing, sneezing, laughing, pushing, pulling, any sort of transitional movements. The good news story is pelvic floor physiotherapy has been found to be first-line defense before any other non-conservative treatments are considered. Whereas urge incontinence is the type of incontinence people are reporting when they're not quite making it in time to the washroom. So they have a strong urge and they're running to the washroom and leak before making it there. So they essentially have an inability to delay voiding. Urgency can occur without having incontinence. So urgency is the individual that doesn't have much warning and they have a strong desire, but they are actually making it in time. And frequency, as I mentioned, is individuals that are voiding more than 8 times in a 24-hour period. Functional incontinence is urine loss associated with cognitive or physical function. So what reason why I wanted to put this on here is that, as much as I'd like to say we can do everything with the pelvic floor, incontinence can be beyond the pelvic floor dysfunction, and it could be actually driven by the physical or cognitive impairment. And then mixed incontinence is the type of incontinence where people are expressing leakage associated with coughing, sneezing, laughing, but then as well with urgency. Like stress incontinence, this type of incontinence has been shown to, pelvic floor physio has been shown to be first-line treatment. Okay, we're going to turn our attention to prolapse, and prolapse it's an annoying, subjective complaint. So it's not a disease, but it really affects quality of life. So it's when women are expressing that they feel heaviness in their perineum that's preventing them from doing activities that they enjoyed doing before. They may report that symptoms get relieved when they're lying down or taking any sort of load off of their pelvis. Again, good news story is that pelvic floor physio can help these individuals. It's been shown to be not only cost effective, but effective in reducing symptoms and should be considered first-line defense, again, before any type of non-conservative treatment is suggested. There are various types of incontinence and various types of severity. I won't go into that, but regardless of the type and regardless of the severity, we do play a role. So when people think of pelvic floor training or pelvic floor therapists, they often think of Kegels. And by this point, you might start thinking that, Kegels are really not a one-size-fits-all. It depends on the dysfunction of the tissues. So as a therapist, we really need to understand what's happening, what is the integrity of the muscles in order to, determine treatment. As much as, we can assume that those with the weak and lengthened pelvic floor might present with stress incontinence, and those with the short, tight pelvic floor might present with dyspareunia. In fact, there could be some overlap. Every individual is unique. So, that being said, we've got to address what we find, not what we would assume to find. So we've talked a bit about the overactive pelvic floor, or the hypertonic pelvic floor, the short, tight pelvic floor, so many different definitions for it. I want you guys to understand that, like any other muscle in the body, the pelvic floor needs to be able to contract and it needs to be able to relax. And when the pelvic floor muscles are not relaxing, it can actually impact bladder, bowel, and sexual function. And in turn, it can create a whole slew of issues. So in order for us to have proper bowel, bladder, and sexual function, we need to make sure that these muscles are working, again, not only to tighten and provide support to the pelvic organs, but as well as to be able to relax. There are a number of reasons why muscles become tight and overactive, and some reasons, and not limited to, is joint hypermobility. So when the joints are hypermobile, the muscles are trying to work really hard to create symmetry within the joint. Other reasons may be, in fact, underlying weakness in the muscles or abnormal behaviors with respect to bowel and bladder function. So again, as a therapist, we need to figure out what the driver is. We've talked a lot about anxiety and distress this morning amongst those with persistent pain, and anxiety, fear, any sort of catastrophizations, ruminations can also drive tension in the pelvic floor. So we need to break the cycle and figure out where most work needs to be done. So pelvic pain is really, a broad word that can describe a lot of conditions. We talked a bit about dyspareunia, which is pain with intercourse, but I did want to mention a few of these other conditions. Vulvodynia, vestibulodynia are painful conditions in the vulva, which can in fact cause dyspareunia. And painful bladder syndrome and IC are pain manifesting in the bladder, and they also can cause dyspareunia. So again, I wanted to make a note here that as much as the pelvic floor may be the initial driver, it may be a secondary issue to another condition happening. We know that there's a lot of organ crosstalk happening, so we, can't forget to ask the questions with respect to, what's happening with bladder and bowel function and vulvar pain. And so there's a lot of overlap, and we know we've mentioned a lot with gastrointestinal issues today, so a lot of comorbidity here. So how is it that we treat both a tissue issue and a nervous system or persistent pain issue? So I often describe to my patients what pain actually is. It's an emotional and sensory experience associated with actual or potential danger. And I think the key word here is the emotional component that we sometimes forget. Thoughts and attitudes, catastrophization, all of that can create nerve impulses, which in turn can increase our pain experience. So I think helping our patients understand that the pain is 100% real, it is an output in the brain, and that looking at stress and our attitudes, our beliefs, and really trying to reconceptualize our pain can be really helpful. Treating the central nervous system. So those with a persistent pain, we know that we want to try to evoke a relaxation response. We want to give them the opportunity to turn on their parasympathetic nervous system. And so we can do this with various exercises, such as guided relaxation, meditation, yoga. It's funny, I had an asterisk beside my yoga, and then I took it out because I didn't want everyone to assume that was my favorite exercise. But nonetheless, like Christina mentioned, we have to be cognizant on the type of yoga these individuals may or may not want to, get involved with, and something that's not putting their joints at end range. So I think Qigong or Tai Chi is a fantastic alternative. It's a way to create smooth motor coordination in a really safe way and helps to retrain proprioception and awareness. Using novel, fun, non-irritating exercise is really important when we have persistent pain. The brain likes redundancy, so again, choosing something new and different. There's been a lot of talk on mindfulness, and we know that the evidence supports that it is really helpful for persistent pain, sexual dysfunction, as well as anxiety and depression. CBT, or cognitive behavioral therapy, any individual who has any sort of cognitive distortions that need to be addressed to help change behaviors is again something that's really helpful. Graded imagery, exposure, and body mapping. So we, as mentioned, I treat women and men, but women with dyspareunia, they may be fearing any sort of accommodation. So using stepwise progression with dilators, which we'll talk about in a few slides, is really important to help debunk the fear. Social connections, we know that having a good social network is one of the most powerful analgesics. When people are in pain, they often start to withdraw from their social network. And so as a physiotherapist, what we want to do is make sure that we are helping them to be able to return back to their ADLs and what they want to be doing, so they can again experience the fun that they used to experience. Positive affect. Positive affect means, how does somebody rate or report the joy and happiness is in their life? And we can measure this with an outcome measure called the PANA. And when we notice that positive affect is low and there's high negative affect, using gratitude training is really useful. So we want to give good education for the individuals with pain with intercourse or any sort of vulvar discomfort. We give them education on their vulvar care, no soap in the area, water only. What does normal bladder function look like? Looking at their patterns and their behaviors, talking about bowel movements, what's normal for them, what's the bowel consistency. Bladder and fiber diaries, if they're voiding quite often, we want to again monitor to see if we establish any patterns. If constipation's an issue, again, is fiber an issue, water intake an issue? Are they eating or drinking things that could be causing them to experience more symptoms? And then, of course, behavior modification. Of course, as a physio, we talk about posture, but as Christina mentioned, we're not looking to make everyone stand up tall, shoulders in line with their ears, bum tucked in, etc. What we want to do is figure out, is their posture perhaps driving some of their issues? Is it perhaps creating a short, tight pelvic floor? And if so, we've got to be able to teach them that, the pelvic floor muscles need to synergistically work with their deep abdominals and their diaphragm in order to have proper mechanics in the pelvis and the lumbar and thoracic spine. And of course, we use our manual treatment techniques, various techniques with the soft tissue, the connective tissue. We really want to treat in a non-threatening way, so using non-noxious stimulus, so we don't become the danger, we don't become the threat. We want our patients to feel safe in our treatment room, so we, again, can evoke a relaxation response, turn on the parasympathetic nervous system, which in turn can help with tension in the pelvic floor. I mentioned about graded exposure for those with dyspareunia or pain with intercourse. So we use dilators and wands, again, to help debunk the fear and help them feel more confident to have accommodation. And then, of course, if there's underlying weakness in the pelvic floor muscles, we treat that through functional strengthening that's tailored to the individual. We can also use biofeedback, electrical stimulation, or vaginal cones. So really the take-home message I wanted to bring today is if we want to practice evidence-based care, then pelvic floor physiotherapy should be considered in this population. And I also wanted to make a clear note that tissues stay better when the nervous system's in check. So we can't treat tissue issues without looking or addressing the nervous system if it is a driver. And lastly, if you're in a need for a pelvic floor physiotherapist, Pelvic Health Solutions is a teaching company in Ontario. On their website, there is a list of pelvic floor physiotherapists anywhere in Ontario and in Toronto. I personally do treat out of downtown Toronto. Nonetheless, downtown is quite large, so there's therapists all throughout the city. If there are any questions specific, you can send me an email and I'd be happy to answer or give you a personal recommendation as well. So I'd like to thank you for having me here today.